This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
Good morning, everyone. Thanks for getting here on time. We've got a session on what's research done for me. First, we got Jack Iwashyna from the Veteran Affairs, normally currently at Monash University, on sabbatical with us. He's going to talk to us about how we can make RCTs more useful and understanding the results we get from them.
Good morning. It is a distinct honor to have anyone in the audience at 8:30, because Twitter would suggest that many of you were still awake and engaged in important social and scientific discussions very, very late into the evening, you in particular, Jean-Daniel. And it's also a bit of a privilege to get to kind of be the opening act for you two here. So thank you for coming to see Jean-Daniel and Steve. They're going to give great talks. All right, do we think if we go?
Yep.
Awesome. Some of you may have been in the room yesterday where I got to experience giving a talk without my slides for a little while, so I'm slightly post-traumatic from that. So before I get any farther into this, let me say that I work for the Department of Veteran Affairs, and so I have to say that this work does not represent the views of the U.S. government, the Obama administration, or the Department of Veteran Affairs on how to analyze randomized controlled trials. I have no conflicts of interest, and there's a group of co-authors who've been working with me very hard over the last decade to try to, over the last year, to try to teach me this and develop this line of work. My daughter's also in the background, and she's the one who just suggested maybe I should move in front of the microphone as opposed to off to the side of the microphone to make it easier for you to talk. So if you can hear me now, you should thank the blonde girl in the fourth row back there. So what I want to talk about is to sit in that tension that many of us have to sit in, where our job on the one hand is to produce clinical evidence that's rigorous and true. But our job on the other hand is to be a doc at the bedside, taking care of not a population of patients, but taking care of this guy here and trying to figure out how to make this guy not dead. And I want to suggest that the ways we've tried to optimize our search for truth have in some cases led us to throw away information that would be helpful for taking care of individual patients. And I want to talk through an argument that's going to suggest not that RCTs aren't wonderful. It's going to suggest instead that RCTs are so wonderful we should help extract more information from them to help us be better at the bedside. Because we all have a simple dream, right? When I walk to the bedside, I've got a patient, I'll make a diagnosis, and then I'll think through sort of what are the benefits and the harms of alternate treatments, and if the benefits are greater than the harm, I treat them. And indeed, this goes back to what for many of us is sort of the foundation of modern medicine. Many of you guys will have read Guyot, Sackett, and Cook and their User's Guide to the Medical Literature, right? This was, for me, one of the touchstones of why I fell in love with internal medicine and critical care, right? This ability to think hard about how things work. And they have a great paragraph that says, will the results help me in caring for my patient? And I'm going to be a bad speaker and actually read a slide to you for a minute here. So the first issue to address is how confident you are that you can apply the results to a particular patient or patients in your practice. If the patient would have been enrolled in the study had she been there, that is, she meets all the inclusion criteria and does not violate any of the exclusion criteria, there's little question that the results are appropriate. And so that's pretty straightforward, right? If they would have been in the trial, then it's easy. Just do what the damn trial says. And doubtless this will come up later today when Jean-Daniel and David and I have a little conversation about a few fascinating trials in the Jamageddon session. But there are examples where this turns out maybe not to be true. So perhaps the best is from the stroke literature, right? So this is a great trial published in the New England Journal, so it must be true. Notes that carotid endarterectomy is highly beneficial to patients with recent hemispheric and retinal transient TIAs or non-disabling strokes and ipsilateral high-grade stenosis. Basically, you should go in and clean out the carotids. But a guy named Peter Rothwell went back and looked at the data within the trial. And so everyone who's on this slide was in the trial themselves, and this is their own data. And he divided people into 3 groups based on their predicted risk of having a stroke and whether they were randomized to get surgery or not. The people in the bottom row who had greater than 15% risk of having a stroke within the trial, they benefited dramatically. They had a number needed to treat of only 7. So for every 7 patients you did a CEA on, you prevented 1 stroke. For people within the trial who had a 10 to 15% risk, there was still a substantial reduction in the number of strokes in the group who got surgery. But people within the trial who were exactly included in this report, who had a less than 10% risk of getting a stroke, every 71 people you did this on, you caused a stroke that wouldn't otherwise have happened. And that's a little disturbing because it suggests the simple dream that Dr. Cook and her colleagues were selling us is maybe a little too simple. Maybe it's not simply a case that if the net benefit's greater than 0, I treat. Maybe a group of people, including John Ioannidis, Rod Hayward, and Peter Rothwell have argued, we need more information from the clinical trial and about each individual patient to know whether or not to apply the results. And this is important not just in our clinical practice, but those of us who have to live in a world where we have guidelines or performance measures. Pretty much the standard way you make a performance measure in the United States is you get somebody to write a guideline that's based on the inclusion criteria of that trial, and then you say, if you meet the inclusion criteria, we're going to benchmark you on how often you give the therapy. But the CEA data would suggest that might not be right. So what are we supposed to do? What we're going to go through and talk about is some work that's going to be coming out in the Blue Journal, the American Journal of Respiratory and Critical Care Medicine, in the next couple days, I think, on the implications of what's called heterogeneity of treatment effect by baseline risk. We're going to argue that you should just about always expect it, that particularly in the ICU where we care for a wide range of patients, it's ubiquitous. We're going to talk about how it changes our interpretation of positive trials. There are still a few of those in critical care. We'll talk about how it changes our interpretation of negative trials, of which we have many, many in critical care. We'll discuss, hopefully, a few of the objections that some of you will be raising. I'll try to cut Steve off at the pass here before he starts saying, but Jack, that's surely not right because of this. I won't get to all of this. And then we'll talk a little bit about what the heck we're supposed to do with it. So let's go through some basic logic. I was taught sort of a lot of bedside physiology by using markers on sort of windows, and so we're going to do that same kind of logic. So think about a patient. And if you think about patients who are untreated, you have here on your horizontal axis the untreated risk of death. On the vertical axis, their risk of death. If they're untreated, their untreated risk of death is their risk of death. That's the most complicated thing I'm going to say today, so don't worry, we'll be able to keep going. But of course, if they're treated, we give them a therapy that we believe improves things. Most commonly, we report a relative risk reduction in the abstracts of our trials, and what that suggests is that bends that curve down a little bit. The difference between those two curves is, of course, the absolute mortality benefit at any given level. And it makes sense that the absolute mortality benefit must be smaller when people are at less risk of death. If you're not going to die anyway, my therapy can't do that much to help you, keep you from dying. And you can take all those little blue arrows, and lump them up. We change the axis here, so the axis is there, and now the vertical axis is your reduction in risk of death, and just draw a line across the top, right? And so that line just is the same triangle that we had between the orange and the gray line. Now, at the same time that you're getting this benefit, if you have no side effects, sorry about the flipping back and forth, the therapies we give patients often have a side effect risk. For the simplest point, let's just assume it's a flat line. And I'm thinking here a lot of ways of Xigris. We all remember Xigris. Many of us in the room love Xigris for a number of years, and then we don't anymore. But Xigris is sort of, right, Xigris is a great drug, right, where at some level your risk of bleeding kind of happened when you got the drug, regardless of whether or not it was going to help you. And for lots of things, there's reason to think there's that relatively constant side effect risk of therapy. And so you just combine the two. There's an absolute mortality benefit if you don't get a side effect, and there's a side effect risk. And you can imagine then that there are three benefits, three regimes of benefit. There's some places where the blue line is above the red line, and that means it's clearly good. These people your expected benefit is higher than your expected risk of death from a side effect, and so you should give it to them. There are some people for whom you shouldn't do it, right? Where the expected benefit is below the expected side effect risk. And there are some people in the middle where you need to have a conversation. And I think the key question when we need to move from an RCT, when I need to take care of Alex here, who's probably getting increasingly uncomfortable with that thought, is are we in A, B, or C? And that's a question we care about at the bedside of each patient, not for the groups as a whole. So this all hinges, of course, to be interesting on there being a heterogeneous group of baseline risk. If all your patients have exactly one baseline risk, then it's easy to know where it should be. So we went and looked. In the U.S. Veteran Affairs hospitals where I worked, we look at patients with non-postoperative mechanical ventilation. And we see there's an enormous variation in their risk of death. Median's about 35%, runs from about 3% up to about 97%. You might say that's the VA. Anybody who works with veterans in the U.S. knows they're a lovely population, but they're not representative of all Australians. So we went into the APD and pulled out of, this is Australian and New Zealand data, not just Australia. I understand that's a sore spot, and two different countries, notwithstanding what they say in Melbourne. And so we looked at that same distribution for people who are non-postoperative mechanical ventilations with a length of stay greater than 24 hours and who are not drug overdoses. Because, good God, the APD has a huge number of people who have drug overdoses in them. And you see, you guys got a few lower risk patients than we do in the US, but there's still a wide distribution of risk of death. So that suggests that this is at least worth listening to a little more of the talk. So that's the logic of HTE, the heterogeneity of treatment effect. What does that mean for interpreting positive trials? So what we did was we said, let's stop and go through and simulate a whole bunch of positive trials. And the great thing about simulation is I get to play God, right? So within Stata, I can set exactly what the benefits actually are, and then we can run imaginary trials and ask how often does a trial design give me back the truth that I coded into the program. And so unlike real trials where you're never quite sure what truth is, see also, for example, the proning trial we'll get to discuss later today where I'm still not sure what truth is, we'll come back and ask, how often did we get truth? So we said, let's assume we're running a therapy that actually works. It has a 20% relative risk reduction if no adverse events. It's got about a 3% risk of adverse events, both known and unknown. And let's run this. This trial's about 2,500 people, so well-powered trials, just sampled at random from the VA's respiratory failure group. And what do you get? You find out this therapy works marvelously, right? It has an observed relative risk reduction of 0.85. It takes the absolute risk from a 40% of risk down to a 33% of risk down. These numbers happen to have just come out, but they look a lot like the low tidal volume numbers. And you go, woohoo, you're psyched, right? You've got an enormously publishable trial. You go to press. But let's look within deciles of baseline risk. So, of course, every patient has some baseline risk. And you can divide things up, and within each decile of risk, compare the treated versus the untreated. And what you see is the drug works spectacularly well in the highest risk patients. You have a number needed to treat of only 8. But on the other hand, as you look down on the left side of those curves, suddenly the black bars, which are the untreated, and the treated bars in blue start to look awful similar. And in fact, you see that in the lowest risk group, even though this was a wildly positive trial, 1 in 10 patients was in the lowest risk group, and you're expecting to at least not help them and maybe even harm them when you give them this therapy. That's a little disturbing. So what about negative trials? How does this change our interpretation of negative trials? We're going to take exactly the same setup. We're going to turn down the relative risk reduction a little bit because we know 20% gives you these wildly positive. So let's turn it down to a therapy that in truth would give you a 15% relative risk reduction. Same adverse event, same population. Now, 45% of these trials are negative in the sense that there's no statistically significant difference between the groups. But when you look within the deciles of risk, you see a very similar pattern. Again, people who are at low risk are harmed because their adverse event rate is greater than the expected benefit. And there are a few more of them, as you'd expect in a negative trial. But nonetheless, these negative trials suggest people over in the far right are still having a huge benefit from this therapy. That, in fact, their number needed to treat in the highest group is only 9. That's a number we'd all take. The number needed to treat in the second highest group of only 14. Potentially tremendous benefits that are being hidden because we're not looking for this heterogeneity of treatment effect by the individual groups. And what this means is a bit of a conundrum for those of you, and those of you in ANZICS who enroll patients probably face this more than anybody, that you can imagine a therapy that has some true net benefit profile, right? This is truth over on the left side. You guys can't see this. It's the exact same blue and red curves we've been looking at. But you set your enrollment criteria, and you get 2 slightly different patient populations, right? And one, you've got enough people over on the green side, and so yay, you've got a positive trial, and you've got something that now goes on to become standard of care. But the exact same therapy that happens to get people from a little bit of a lower risk distribution, and instead now you have a negative trial, and we throw away a therapy that might be truly helpful for high-risk patients because we didn't happen to look to ask the careful enough question. We asked one question, does it fit everybody, as opposed to asking the question for individual groups. So you might be saying to yourself, that's really nice, but let's go through some objections, because damn, you made this world way simpler when you were running these simulations than the real clinical world we live in. So let's go through at least 2 objections. Let me say the reviewers for this, the reviewers were a little skeptical initially. One of my co-authors in the room and is nodding. We went through about 75 pages of revise and resubmit comments with them. And as a result, the published version also includes an innovation, which is the first time I've ever published an FAQ that goes along with the article. So it's a 3,000-word article with a 5,000-word online appendix because reviewers ask me a host of questions. They ask me questions like, well, so that's good for respiratory failure, but what about other things? And so we reran all our simulations in a sepsis distribution. You get exactly the same sort of answers. They ask lots of hard questions. Let's go through 2. So the first is, and this, right, like this is clearly something that was just a simplification. In reality, adverse events do not happen to everyone at the same rate. Sicker people have more bad things happen to them than less sick people. And so maybe I'm just jimmying the numbers by keeping that adverse event rate flat. What if it actually bent up? So we reran the numbers. We reran the numbers where the adverse event rate increased by an order of magnitude between people who are in the lowest decile risk and the highest decile risk. Kept the same population average, and you get essentially the same number. While there isn't harm necessarily in this one simulation in the far left group, there's order of magnitude differences in the number needed to treat. Big differences in the effectiveness between 70 and 74. So even if the adverse event rate isn't flat, that doesn't make heterogeneity of treatment effect go away. You might also say, but look, it's the ICU. Our treatments only can fix one thing. There are all these other things that might be killing our patients in the ICU. It may be their cancer that they had before they came in with that I can't fix. Or it may be before I get to see them, they already have other organ dysfunction that's set in that my therapy is not going to fix. What does that do to your math? Well, the first thing is it actually turns out that it makes it really hard for us to develop positive trials. So let me go through this table with you slowly. So what we have in the left column is how much of all of the risk of death is potentially responsive to your treatment. The top line is we're using a magical treatment that could work for 100% of their risk of death. So the only thing they can die of are things that our therapy makes better. And this is exactly the numbers we used. You need we tested something that gives you a 20% relative risk reduction. But as the fraction of the things that are going to kill them get affected by your treatment has to get spectacular. So by the time you're down to a world where only 25% of the patient's risk of death is potentially affected by the treatment you're testing, that treatment needs to fix 80% of the people who have that risk of death, right? It needs to be extraordinarily efficacious in order to have any chance of having a positive therapy. And this may be part of why we have so much trouble finding new therapies in the ICU, because finding something that works either for everything that can kill someone or really, really well for only a subset it's a hard challenge. But even if you do this, and you look within each of these different groups, you still see here tremendous heterogeneity of treatment effect. The top group was exactly the same, top line's the same data we've been talking about, that number needed to treat that vary between 6 and affirmative harm. Whereas even if you can find a therapy that works really well, but only for a small subset, you still get tremendous heterogeneity of treatment effect. So the reality is that many of the things that kill patients, even if they're not treatable, it's really hard to develop an efficacious therapy for them. And even if you can develop an efficacious therapy, the logic of heterogeneity of treatment effects still applies. Okay, so if you've bought all this, the question is, what am I supposed to do with this? I think the first answer is, and I feel particularly privileged to get to say this down in where many of you enroll in the clinical trials group, and I think I'm mostly talking to you, Jeff, during this slide here, is when we're designing our statistical analysis plans, we should at a minimum plan pre-specified subgroups where we stratify by baseline risk of death. And let's look for this in the same way that we routinely look for variation in treatment effects by things like age or Apache score or other stuff. On a day that I'm feeling very egotistical, I would say we would think this should sort of be your first among equals subgroup, but that's entirely a theoretical argument. For the next 5 years, I would just suggest that when we're lumping together our list of pre-planned subgroups, let's include heterogeneity of treatment effect by baseline risk as one of those, and let's see if this proves to be as important as these arguments would suggest it might be. Those of you who are editors, or those of you who review for journals, likewise, could demand that this be included. But the basic point here is pretty clear, that our overall baseline risk of death, not just the specific physiology, fundamentally shapes each patient's opportunity for benefits from a therapy. High-risk patients may often benefit substantially more from our therapies than low-risk patients. But those high-risk patients are going to die anyway. They were high-risk beforehand, and the therapy is not going to normalize that risk. But part of the challenge here, of course, is that we're going to get that wrong when we remember it. When we see the low-risk patient who we give a therapy that does almost nothing for, they survive, and we go, woohoo, I saved them. Whereas when we see a high-risk patient who maybe we take from having a 95% risk of death down to a 50% risk of death, what we remember and what we feel in our gut when we sleep at night is that 1 in 2 of those patients still died. And so that availability and salience bias is going to tend to make it hard for us to remember this, which is precisely why we do randomized clinical trials, because we need the numbers to help counteract our psychological biases. We need also to consider being willing to withhold a supposedly indicated therapy from very low-risk patients or in modestly low-risk patients with a higher likelihood of adverse events. But I want to be clear. I love evidence-based medicine, and this is not an excuse, as perhaps one of you in the room is thinking it is, that, well, Iwashyna said that HTE stuff means that our RCTs don't apply, so I'm just allowed to willy-nilly ignore things, and I can give everybody 12 cc's per kilogram of ideal body weight. That's not what this is saying. This is saying there's a very specific context in which traditional guidelines may be wrong, and we should think about varying from them. But most of the time, the mean is still a better message than just making stuff up. So thanks very much for your attention. I'm happy to take questions, but I haven't run on too long.
While we're getting our first question, there's one from the Twitterverse.
That's awesome.
Is there a risk that trialists will game their results by finding subgroups that show benefit, but now they've got a sort of new reason that this is a sort of valid thing to do.
Yes, there is. Anytime you let people fiddle around with subgroups, there's a potential risk, and that's why you keep Jeff in the room, right? So the point is you have to pre-specify these, and like any other subgroup analysis, it should be hypothesis generating. It's not compelling proof. If you're pretty sure, particularly if you've got a negative trial, but you found the one true subgroup that your therapy really works for, you do exactly what the proning people do, right? You run 8 negative trials, honing down on that one group, and then you run a pre-specified trial to check it. The reality is many of us have to interpret subgroups, however we have to interpret subgroups, at the bedside while we're waiting for good trials to be run. That's true, and that's as true of this as it is of anything else. But in terms of when you're provably right when you do a pre-specified trial, when you do a trial in a pre-specified group that has this as your inclusion criteria, and that's the right way to work on it.
Thanks, Jack. I've sort of had that sort of where you were when the man walked on the moon type moment. I know that I will always remember where I was when I heard this for the first time, because I think that this just profoundly changes how we need to go about our business.
That's like the nicest thing anyone's ever said to me.
Baseline risk is correct me if I'm wrong, baseline risk is an amalgam of age, physiological disturbance and comorbidity. Have you modelled at all how the different impact of those 3 components of baseline risk can influence these conclusions?
The short answer is no. I'd say the second answer is at some level what matters for this pragmatically is discrimination, not calibration. And we get to live in a world where there are a ton of great scores already done that more or less discriminate pretty well, right? Apache 2 actually still discriminates spectacularly, even though if it expects us all to die because it was calibrated during the Reagan era. And so we can probably just use all of those. A second question you're asking really digs into that last set of analyses, which is kind of modifiable versus unmodifiable stuff. And let me say, in this context, perhaps differently if we're out getting a drink, but in this context, that's still an area of active exploration where we're not sure what the right thing to do is yet.
Can I just follow on by saying, is this an argument that, so the question that you related to in terms of responding about Jeff's role, should we be stratifying randomisation by baseline risk?
So I feel like a certain degree of modesty is appropriate when someone who's never run a clinical trial walks into the Australia-New Zealand annual scientific meeting and starts telling you guys how my computer program tells you should be doing your business. If this logic proves to be correct and proves to be found true across a variety of trials, this would argue strongly for doing stratified to ensure you have balance between your arms. I think it is premature to include this as a stratification variable, given the hassle that that causes in the actual execution of trials. Perhaps in a decade we'll be there, but I think we're all intensivists, right? We have spent much of the last 20 years hearing really compelling logical arguments about why something was going to make things better, testing it, and then finding out it didn't actually make things better or it made things worse. So let's go prove that this works before I make your life more complicated in running a trial.
Just had a comment and a question. Fantastic talk, Jack. Thanks, and I agree with Steve. It's a very important issue that we need to be building into our trial design. Exactly how, we're going to have to have a bit more discussion about. Comment was, as you get down into smaller and smaller subdivisions, you end up with greater and greater uncertainty, and I think you've commented to say that really this is hypothesis generating, and you probably need a sequence of trials to try and hone down on where the real effect is, or the effect is greatest. My question is, all your modelling assumed that the heterogeneity of treatment effect across subdivisions, deciles, is linear. And I just wondered if in reality we will see that it's not linear and there might be threshold points and et cetera, et cetera. What do you think?
So I would say yes, but if you find that a credible question, I've won already. Right, so I think it's an empirical question as to what the shape of the risk-benefit function is over deciles of risk, but it's an empirical question you can only explore if you start exploring it. So yeah, these are simplifications just to show kind of, right, this is kind of an existence proof, right, that it's plausible. We need to go see what these things actually look like out there in the world before we know how to do this, and so we've got to measure it a bunch. Thank you guys very much.